Well, good morning and welcome to the Board of Directors meeting of Nottinghamshire Healthcare NHS Foundation Trust. My name is Paul Devlin, I'm the Trust Chair, and you're very welcome to this meeting, whether you are able to watch us live or indeed are watching a recording of today's meeting. We usually start our board meetings with a patient story as a way of us just framing our board meetings as a reminder on why we're here. Unfortunately, for various reasons, today's patient story we haven't been able to follow through with the one for today, although we're very much hoping that the person who is going to speak with us today will be able to at a later meeting. So in which case I'm going to move us straight on into our routine business. In terms of welcomes and introductions, I just wanted to give a welcome to John Singfield, who's the Deputy Director of Planning and Partnerships, who's going to be observing the Board of Directors today. John, I think it's your day 5, so you're very welcome to the Trust, and I look forward to meeting you at some point in person. So if we move on, I don't think we've actually got any apologies today. I think we are a full house today. In which case, if we can move then to our declarations of interest and just ask if anybody has got any specific declarations of interest for today's meeting, please.
Hi, Paul. Steve Banks, Non-Exec Director. Yes, just want to declare my appointment at Sherwood Forest Healthcare Trust.
Thanks very much, Steve. I don't think there's a specific conflict for us today, but it's useful to note that, and also congratulations on that appointment, Steve.
Thank you.
So I'm not seeing any others being identified, thank you. We haven't received any questions from the public for today's meeting, so if we could go to the minutes of our November meeting, please. And if I could just ask colleagues, first off, whether you can give me an indication of agreeing that these are an accurate record of our meeting, please. I'll just pause for a moment for just to give you a chance to indicate if these are an accurate record, please. That's great, thank you very much. And if we go to the matters arising and the action log, the log is there. I think we've got progress rated green in relation to actions on most of those, other than ones that the deadline is still forthcoming. So I'll just pause to see if anybody has got any questions in relation to the actions. Okay, in which case let us move on then to the next item, which is a system update. John, I think you are going to just give a bit of a verbal update in relation to the system, which I know is moving at pace, which is why there's not a paper as such. But I think this is a useful opportunity just to highlight if there are any key headlines to bring to the attention of the board. Thanks.
Thanks, Paul. John Brune, Chief Executive. Morning, everybody. Apologies, there's nothing written down on this. A few bits are dotted it through my Chief Exec scan a bit later on. But as Paul says, there's a lot going on in the system space, and I just run through a few of the headlines. So there's Chair and Chief Exec designates been appointments made. They will need national ratification before they're confirmed. It's likely they will be, and the ICS team are now into recruiting into non-executive director positions, and the remaining exec director positions on what will be called the Integrated Care Board, the ICB. That there's a relatively small number of director positions: medical director, nursing director, director of finance. It's been agreed there'll be 2 director representatives from the local authorities, 1 from each, and there'll also be a single provider director from the 3 large providers from ourselves, Nottingham University Hospitals and Sherwood Forest Hospitals, and that will rotate around a frequency to be yet decided. So that's the ICB, the Integrated Care Board, which will come into fruition in shadow form from January, and then will be pending support through Parliament, a substantive thing from April 2022, and therefore the old ICS board, the Integrated Care System Board, that we've been attending in recent times, has had its final meeting. The slightly confusing thing will be that a lot of the people will remain the same, but it's really important to note the change, both in the terminology, but also this is the sort of glide path into becoming a substantive organisation, which is different from the current ICS setup. In relation to, in alignment with the ICB, there'll also be an Integrated Care Partnership, or ICP, which is a much broader stakeholder alliance, which is sort of co-owned and co-hosted by both NHS and local authorities, whereas the ICB is more NHS led. The ICB will be the sort of point of the triangle, that where NHS business will flow through in terms of reporting and accountabilities. You'll also be seeing increasingly mention of something called provider collaborative at scale. So some of the meat and content of integrated care systems will be, to a greater or lesser extent, a number of provider collaboratives. So this is providers working together under an agreed set of principles and priorities. And there'll be different flavours of provider collaboratives. Some will be quite formal, where there'll be a lead provider contract. For example, our Impact service has been up and running for over a year now. Is a formal contract of which we're lead provider out of 9 across the East Midlands for forensic services. But there'll also be different types. So we're working at describing a provider collaborative at scale with the 2 other aforementioned acute trusts in the system, and we've started to identify some principles, priorities and timelines for that becoming a thing in itself, also in shadow form from January and in reality from April next year. And we're working at what sort of things we'll be looking at. Obviously, staffing is a critical issue to all 3 providers, but also where we can be more efficient and describe better functioning patient pathways, for example. Exciting part of the developments and a real opportunity, both from a trust perspective, but from a system perspective of some of the ambitions that we'd like to achieve in terms of transformation. And then just a couple of things just to finish off with, Paul. There's still emerging legislation around how all this will work, and as I said earlier, that it still has to be all agreed and signed off by the Lords and Parliament, so subject to change. The tier of within the integrated care system below the board and the partnership I've described is something called place-based partnerships, of which there are 4 places within the county: Bassetlaw at top, Mid Notts, City and South Notts. How they will run, their responsibilities, accountabilities is still quite vague in terms of whether they'll get, for example, delegated authorities to run things, to have budgets. So there isn't very much sort of crystallized that I can share with people. The other thing to note, though, I'm sure people are aware, is that CCGs will cease to exist from April. There are two currently in our ICS, the Nottingham and the Notts and the Bassett Law one. They will become one. There's an agreement that staff below director level will transfer across in the first instance. So that will be a big change into, again, that not just the labelling of things, but the organisational form. And then two more administrative things to finish on. One is that from January we'll have a section in the board papers that is headed system. So that we'll need to have a formal space where, as a sovereign organisation trust, we can receive and send out papers. So there'll be a specific box for that. And secondly, that we are planning to have a number of NED events in the early new year, so that we can present some of this in a bit more detail and provide a more discursive passing on of information and ideas about how we develop this further. Thanks.
Great, thanks, John. And it is complicated and fast moving, but I think it's also critically important that we are aware as a board, and good that you pointed out that actually this is the start of us formally bringing integrated care system work into our board, so that we can give the appropriate scrutiny as a full board. And those NED non-executive director sessions that you referred to, really important for us to make sure that all of us are able to contribute to how we play our part in the system. So I'll just pause there and see if anybody has any questions or comments in relation to what John has summarised in terms of those changes. I'm not seeing any. I think, John, the only comment I'd make is that underneath all of those transformation changes that are taking place, including a lot of structural stuff, but it's actually also the how we're working, there is a lot of time and effort going in from yourself and executive director colleagues, and it's something, again, as a board, whilst we of course want to play our full part in the system, we also need to make sure that we are balancing, of course, the leadership that you and colleagues continue to bring to our trust, and I don't have any concerns about that at the moment. That's one that I know that you and colleagues are alert to as well, to make sure that we manage all the different pieces that we need to. Okay, thank you. In which case, let's move on to my report. The report is there. Just a couple of things I wanted to highlight. First of all, I'm aware that almost for many months now, my first paragraph has been just acknowledging the pressure that our staff and volunteers are under. I feel like this has been particularly underscored for me this last month because I've been able to get out and visit services. And one of the absolutely common themes is just hearing from our staff about how tired they are, and also just the impact of that cumulative pressure on being able to deliver the very best that they can. And I think it's just really important for us to note, and again, as usual, thank all of our staff for continuing to do your very best, despite this being the end of a very, very long, sustained period of pressure. it's important that we don't underestimate the pressure that is going to be coming through the next few months with us going into winter. And I'm sure that this is going to be something that gets referenced at later points during our meeting today. I wanted to acknowledge that our last board meeting we actually held face to face, and we were very pleased to be able to do that and to actually be in a big room together, partly because of emergent pandemic related changes and the new variant, but also just recognizing that we can alternate between face-to-face and virtual meetings. We've reverted back to virtual for today, and we will be taking decisions on whether to be face-to-face as board each time we're coming up to the board, so that we're doing it in ways that are most effective and also most safe. I referenced some service visits there. Just as a matter of clarity, I wasn't able to visit the Children and Adolescent Mental Health Service, the CAMS and perinatal services due to COVID pressures that were emerging at that time, but I did attend the other services. I wanted to just flag, because it's something that we talk about in relation to our staff as part of our performance report. We talk about appraisal rates, and I just wanted to acknowledge that I've had my annual appraisal in the last few days, which will be being reported through to our Council of Governors and will come into the public domain. And finally, just wanted to highlight the Armed Forces Gold Award event that I was able to attend. It was a real privilege to be there, but more importantly for me was to be able to be there with 3 members of staff who have a particular interest in the Armed Forces Gold Award, which is an award for us saying we are a really good employer who has a focus on the forces, veterans, and indeed reservists. And I was delighted to be able to be at that event with somebody who leads one of our services for both forces and veterans, a veteran and a reservist, and it was a real privilege to spend time with them, and also for them to be able to be part of a very big event with the military recognising many organisations. I'll pause at that moment and just see if there's anything any colleagues want to tease out from my report. In which case we'll move on, and John, will come back to you for the Chief Executive report, please. John.
Yeah, thanks. Me again. I'll take the report as read and just highlight 1 or 2 things to flag to you. So on page 18 of our pack, in the main report detail, just an update on the CQC. So we still don't have a date for a formal comprehensive inspection, which remains a frustration. I know for many teams that, Paul, when you and I go around, everybody's eager for them to come and showcase the work that we're doing, but we don't have a date. And as people know, trusts are inspected on a more of a risk-based flagging system at the moment, and I suppose one of the positives is that we're not flagging any immediate risks to cause them to come. We did host a couple of their regional and lead inspectors at Highbury Hospital in the mental health division on the 19th of November. Although informal, I'm sure the inspectors will have been making notes and taking stock of things, and we know that the areas that they visited are under a massive amount of pressure at the moment. But that the visit went well, and they were there for sort of a good half, 3/4 of a day, and again saw lots of really impressive staff doing brilliant things in challenging circumstances. So it was good to get that under our belts, as it were. From an NHS EI perspective, I've put what the priorities there. Everybody will also know that the NHS and social care system right across the piece is hugely challenged at the moment, particularly in terms of the demands on acute care, emergency departments are full, primary care is full, and that's putting huge pressure on the ability to tackle what's called elective care lists. So waiting lists continue to go up, and there is huge focus from both national and regional teams on the numbers that lie behind this, as well as the demands of the vaccination programme, as well as the demands of the flu vaccination programme, and as well as the demands of the transformation the programme that I briefed about earlier. So hugely difficult politics around all this too, and just what we needed was a new unknown variant just to throw into the mix last weekend. On the next page, 19 in the pack, I'm not going to repeat, I've covered most of that system piece. New into my report this month are some brief summary highlights from each of the divisions. Again, I won't read them in detail, but just to flag a couple of things. Again, sorry to be a bit repetitive, but the busyness of the demands in terms of referrals and business coming in and acuity, not just in mental health, but certainly in the acute care pathways in community health, but also in forensic services too. The whole of the child and adolescent and children and young people pathway was inspected by the CQC, and we've had some good feedback from that. They don't rate when they do these system reviews, but they give recommendations, and that was generally seen as lots of really good positive work going on there. In community health services, as I say, the acute urgent care pathway is really busy, and there is a lot of pressure. As we found out yesterday on our visit to Lingsbar Hospital, on our services to take discharges out of the acute sector, to the point where unfortunately the system has had to open more beds, and we know that that's very much an elastoplast, because the more important transformational change of enabling people to get home with supported packages of care is better practice, but the pressures in that system, again, not just in Nottinghamshire but across the country, is huge. In forensic services, again, to flag that the staffing pressures are really acute, not necessarily just at Rampton, but across the medium secure and low and community forensic services too. Some good news. A body called the National Oversight Group, or NOG, which is the national body that oversees all high secure care, reports directly to the Secretary of State and the Privy Council, no less, visited Rampton on Friday. The team accommodated them and had a great itinerary of visits to various different directorates and wards, saw some exemplary practice, and I know both staff and patients are on top form in showcasing the great care that we provide. And again, the informal feedback from that was really positive, and they went away with a couple of messages that despite their headline ratings remaining inadequate because the CQC have not been for a long time, I think they were really assured that we'd move forward quite significantly. They were going to go back to have further conversations with the CQC about making sure that the ratings that we do have are representative of where we are. And they also got a good amount of input in the requirement for capital to help rebuild the mental health wards at Rampton, which are long overdue a new unit. In the communication summary, there's a lot of detail there. I won't go into it, and people can read. Just a couple of things to highlight. One is the COVID pandemic response. People will have seen, I know that the recent media about the Omicron variant, the concerns about the transmissibility and the unknown with regard to the effectiveness of vaccines and the serious illness as a result or not of the new variant. And we're in that phase of another 2 or 3 weeks before that becomes clearer. I mean, it's clearly now being transmitted across the community. The specifics around NHS requirements haven't changed, unlike some of the general instruction we get, but we will obviously pass it on as soon as we get it. Staff continue to be very resilient and tremendous at how we're managing the social distancing, the use of PPE, access to vaccinations. We're I think 96% of our staff have had at least 2 vaccines now, which is tremendous response, and I think it's really important to note to that, and to thank everybody that's availed themselves of a vaccine. Really important, most important thing you can do to protect yourselves and others. And we note also that from April it will be mandatory to be doubly vaccinated, and probably more. The detail of that's being worked out, but to say that, for example, all our adverts for new starters that will be starting in the spring will have that as a requirement, and that's going to be national as well. Ditto flu. It often gets lost in all the messaging. Really important. We've got access to lots of clinics and appointments for our staff to get vaccinated for flu, and just to flag that, please make note and get it done if you can. And then just finally, a couple of things. One to note in the communications bit, the tremendous response we had to Oscars, our highest number of nominations ever. Huge amount of work for the judging panel, but it's a good problem to have. And again, just showcases some of the great efforts that all our staff have made over the year. And 2 final things. One is to say again, another thank you to everybody that has been helping keep the show on the road, is appreciated. And as you say, Paul, as we go around increasingly over the last few weeks, different services that the efforts they're putting in to be professional, and we saw a great example of that yesterday at Lings Bar, and the challenges it throws up at an individual level, to do the best we can for our patients, service users, was quite moving. And then finally from me, just to note that sadly our Director of Finance will be leaving us at the end of the calendar year. Lorraine is going on to pastures new already. And I just wanted to thank Lorraine for what she's done over the last 10-11 months. It's been great having her on board. I know she's really got stuck into both work in the trust, but also the complex labyrinths of the system finances, and has put a lot of effort and passion into ensuring that the system does the right thing around all things related to money, and to wish her all the best for her future career. That's me done. Thank you.
Thanks for that, John. There's, as ever, there's a great deal in your report. We will come back to Lorraine at the tail end of the session, the meeting today. But let's just see if we've got any comments or questions from colleagues? There's a great deal that John's talked about there, and actually quite deliberately there's quite a few things that you've left as read, John, as well. So let's see if there's any particular comments. There's one that I'd like to just pick up, and you may tell me that actually this is easier to pick up in the performance report, John, but you did mention Transgender Awareness Week in your report, and I just wanted to make a connection with some of the challenges we have around waiting lists in all of our services, but actually what we know is that waiting times for our transgender services, which are a really important specialist service we've got, are I think incredibly long, and I think it's something that I know the service works as hard as it can, but I wondered if you'd got any comment about what we're doing in relation to trying to convince commissioners around supporting some of that, and indeed some of what we're doing in relation to supporting people who are on the trans pathways. As I say, it may be that it's more appropriate to pick it up in the performance report, but I just wanted to ask if you'd got a view on that.
Yeah, thanks, Paul. I'll say an introductory piece, and then I see Julie's popped up on screen. Who'll know the detail far more than I. So a couple of sort of summary headlines. Firstly, I think it's really important to recognise that the transgender world has completely changed over the last 5-10 years compared to what was. I don't mean this in a demeaning way, a very niche specialist service previously, and there were very few in the country, and now it's become mainstream with huge demand. We should be proud of our service in the trust. It's got I think national recognition and national reach. We've got some really skilled and expert staff, but as you say, the demands of in-county referrals is huge, and the waiting list extremely long. I know that we're doing as much as we can to focus on that and reduce it where possible. But you're right that I think one of the big issues is the amount of service that is commissioned, and Julie will be able to say a bit more about that. My final point would be that I think it's something that we should continue to develop, and we have got real ambition about becoming not just a regional but a national player here because of the expertise and reputation that we have. But you're right, there's a fundamental issue, isn't it, about quantum here. And I think it's a really important question in the future. With CCGs disappearing, how will these big strategic commissioning conversations take place, and how will they be informed? Julie?
Yes, I'm Juliet, Outfield, Director of Local Mental Health Services. You're right, Paul. We all agree that the waiting times are too long. There is, however, some positive news and change, actually. We are a growing centre, as John's described, so we are a regional service, but we're also responding nationally. So we've had over 1,500 patients transferred into our clinics, actually, with £1 million of investment over the last 3 years. What that's meant more broadly is patients who had been waiting perhaps for up to 5 years to be seen are now being waiting within 2 years. So that's a real positive more broadly. And we've also taken an additional, I think it's 700 patients off national waiting lists through our services as well. We've been very conscious, though, not to do that at the behest of the Nottinghamshire service. So there has been an investment of £500,000 allocated to us, which is for the provision of 4 new staff. So that's 2 consultants included in that as well. So we are seeing quite a lot of investment coming. One of the things that is limiting the pace is actually the availability of specialist skills. So what our services are doing, and they're very proactively doing nationally, is training staff through all of these pilots to increase the capacity. Because it's not just a sort of finance issue, it is access to specialist staff. But I think we've reduced our waiting time by 10 months over the last 2 years, and we'll continue on that trajectory. But we are soaking up, you know, a more broader context as well, which I think is really positive. So that's largely where we're at.
Great, thanks for that, Julia. I appreciate just taking us into a little more detail there, and I know it's something that yourself and indeed others on the exec team are very alert to, but I thought it was worth us just teasing that out in the public board. Trevor, let me bring you in, please. Trevor.
Thanks, Paul. Trevor Orman, Chair of Finance. John, it's a question and a comment really, that it's almost 2 years ago that we were walking into COVID without knowing what the implications of what we could face there. And 2 years later, we've just had the latest variant land on us. And it feels to me that the magnitude of change that the NHSE and I are driving through the trust never changed, regardless of the environment that we were facing. Dramatic change, and yet the same pressures and demands on change have landed on us. And it does feel to me that the time is, we don't know what this new variant can do over the next 12 months, but we know that it's been tough over the last 18. And I'd like to think that the NHSE and I are looking at scenario planning of, if this does have a runaway train for us again, what are we going to do with the level of change that we're driving across the NHS and all the trusts? Because the scale of it feels to me that at some point it becomes overwhelming, that you can't have NHSE and I saying do more integrated care systems, join everything together, when day-to-day work is tough. And I do think that kind of message needs to be conveyed back up the line to give our staff some level of air cover, that it's not just business as usual, because it's not. I just appreciate your thoughts on that, John.
Yeah, thanks, Trevor. Yeah, a brilliant analysis of the challenges. I'd agree. Yeah, it's a really difficult environment to navigate. I think, excuse me, what do I think? I agree with regard to, we can't keep endlessly being on red alert day in, day out. We're already seeing the effects of that, aren't we, in terms of how staff are feeling and how we're all feeling. It's really, really hard. A couple of points. I don't know if anyone saw the Dimbleby lecture last night from the scientist that essentially oversaw the AstraZeneca vaccine development. She was, despite some gloom around the next pandemic could be even worse, which caught the headlines, she's very confident about the ability of the vaccine technology to adapt to new variants really quickly. And we're saying things like, you know, if this one or a next one does prove to be elusive with regard to current vaccine flavours, that new ones could be in the production line within weeks, which is heartening at least. I think that there's a sort of higher level political view that in some ways this is a perfect opportunity, depending on your politics, to really put some fundamental transformation into how the NHS runs. And if you're of a particular persuasion, the narrative goes something along the lines, it's about time that we had a bit more accountability in the NHS, a bit more churn, and to bring some additional private sector ethos into the way we do things around here, because it's you know, it's a bottomless pit of taxpayers' money. Bang the table, let's get red-blooded about it, and there's too much fat, there's too much malaise, there's too much tolerance and mediocrity, and this is a perfect opportunity. And just to underline, that isn't me saying that, that's a in case someone's typing this up thinking, what's he on about? But that's a narrative that I think gets played out. But I think the counter to that is that I've started, you know, on some conversations and some commentaries, started to see a bit of the opposite, which is we're going to reach a point sometime soon where we're just going to have to say, no, we can't do all of this. And so a good example of that is there's some of the real sharp focus on some of the elective care waits. And so there's a key number that everyone's focused on at the minute, which is the people that have been waiting for more than 2 years, the 104-week waiters, for predominantly ear, nose and throat, orthopaedic, planned care interventions. And if you look at the graphs of those over the last 18 months, 2 years, they've just been exponentially going up. And the message from the centre is that, you know, you've got to get them to come down and fast. But obviously that needs theatre space, it needs bed space, and coinciding with winter, that's when it's least available. So at some point something has to give. I think one of our tasks is to make sure that staff aren't caught in the middle of that. It's not an especially great example for mental health, predominantly a mental health learning disability trust, but you see the sorts of tensions that it's bringing, and I think it's in my experience, it's a really difficult set of circumstances to manage. Our task, I think, as a trust and as a board and as an exec, is to manage up as best we can to enable our staff to you know, to not just be resilient, but to access this, for example, the staff wellbeing services, to take leave and to take breaks, and that's really, really difficult. But there's some of the fundamental things we've got to just do on a week by week, month by month basis to get us through it. We'll get there. Winter will pass, and the pandemic will at some point go. But we just got to keep positive and optimistic despite the challenges that we have. Sorry, that's a bit of a long-winded response, Trevor. That hopefully sort of gives an indication of the environment we're in.
Thanks, John. Trevor, I don't know if you want to come back on any of that. I've got a couple of comments that I'll add in a second, but Trevor.
No, I think I appreciate the final comment, John, that our role is to protect the staff, to ensure that we do encourage them to take breaks and look after their well-being so that the patients get the maximum treatment. I think that's critical for our role. So I appreciate your feedback, John. Thank you.
I think I just add a couple of bits. I think, Trevor, it's really important, significant issue that you flagged for us as a board. The couple of reflections I had. One was I was on a call with staff across Nottingham and Nottinghamshire, actually, as part of our disability partnership work, and one of the reflections I had there was that whilst we absolutely appreciate the resilience of our staff, we shouldn't build resilience into normality, and I think that's a challenge for us across the NHS. I do think that there are other pressures that are really complex, which we need to seek to influence. I've certainly heard about the pressures that colleagues working in social care have, which then have a direct knock-on to our services. You know, some of that is as basic as actually we are looking after people who should be in a social care setting, but our social care colleagues are so stretched themselves that they've not got that resource. So there's further complexity there. But I did just want to take from your challenge Trevor and John's response there. I do think that John and myself, and indeed any other colleagues who are on calls where there's an opportunity to feed back up the line to NHS England and NHS Improvement, we should be taking those opportunities to constructively feed back through. And John, as a board, I think we need to note really clearly your point about actually we need to be confident that at times we may need to say no to some things, or no, not just now. And I think that that's a really important part of our approach that we need to be taking as a board. And if I could perhaps encourage that in our board committees as well, and within the executive team's thinking. And I know that, you know, nobody is going to be seeking to stop doing things for the sake of it, but actually there's an important piece there about us just acknowledging those pressures. Okay, let me just see if there's any other comments or questions on the back of your paper, John. I'm not seeing any. So let's move ourselves on. Thanks for that. And I think again you've highlighted some things which will be coming back in as we move on, not least in this next piece, which is our integrated performance report. Lorraine, can you do your usual steer through this for us, please?
Of course I can. Thank you, Paul. I'm Lorraine Hooper, the Director of Finance, Information and Estates. And as we would usually do, I'm going to take us through, a number of our board members will take us through the various parts of the IPR. So we'll start first with quality, and Anne-Maria Newham.
Good morning, everybody. My name's Anne-Maria Newham. I'm the Executive Director of Nursing, AHPs and Quality. Yeah, we have quality first. So the first area that I just wanted to mention is around restrictive practice. And we have a commitment as an organisation and as a trust to reduce both violence and restrictive interventions for our patients. And also we are making a steady positive progress around delivering some of the improvements to ensure that happens. We have dedicated resource within the team to deliver a strategy which is being developed and out to consultation around violence and restrictive interventions as well. We're also part of the National Improvement Programme around restrictive practice as well. And that's really important for us to be able to benchmark ourselves against other trusts that are like ourselves. So despite staffing pressures, and clinical services are currently experiencing a lot of staffing pressures, there continues to be a reducing trend in the overall use of restrictive interventions, which is great for us. We did see a little bit of a spike go up when we went into COVID, particularly last year. We were using locked rooms a little bit more. We had to self-isolate patients as well in their rooms, so we were seeing a few more incidents occurring, but that definitely seems to be on the decrease. The next area for myself around quality is around hate crime, and I have reported this over the last 3 or 4 board meetings to say that we've seen a steady increase in the reporting of hate crime and hate incidents, and I'm okay with that because that shows that staff are able to report, know how to report, and it's such an important area for us to be aware of. But it also shows that they have a little bit more trust in us, that we will do something about it, and it's not a wasted report. So previous months has reduced to 126 for month 7 for October, and it had been 150 for month 6, September. But we've seen a really good response. We've got some really good leaflets out there, worked with our patients to say, what does this feel like for you? We've got some really good, at Rampton, they've got this fabulous electronic board where you walk in and you can see the improvements that we're trying to make around hate crime and hate incident as well. And then the third one, is wards with safer staffing rates that are lower than 85%. I've explained before to the board and anybody who's listening in that we report over and above safer staffing rates. So anything that goes lower than 85%, and also I report anything that goes above 115%. If it goes lower than 85%, what that actually means is that wards have struggled to staff the ward to the establishment that they should have there. So we have at the moment 18 wards that are reporting below 85%, and that is a concern for us. And the forensics division is again the most affected by low staffing levels, accounting for 14 out of those 18 wards. So we have done a lot of redeployment of areas with lower clinical demand to increase the areas of increased clinical demand. Those are the three areas I wanted to point out today from a quality perspective.
Thanks, Anne-Maria, and let's open it up for any questions or comments. I've got a few, but I'll wait for others to have a go first if anybody wants to come in. Carolyn, start us off, please.
Anne-Maria, can I ask you about ward staffing, please? In the report there, it talks about the pressures that we're seeing at Rampton, and I've done a number of visits to Rampton over the last few weeks, and can reflect back, obviously, what you've said, that there are pressures, and this is having a direct impact on patients' ability to undertake activities and things. So my question is, what is it we're doing about those staffing levels to improve that situation, please?
I might have to refer to my good colleague Sue Elcock on this one, if that's all right, Carolyn.
Yeah, of course.
Thanks, Anne-Marie. Sue Elcock, Forensic Director. So I think what we've been doing is, so in the height of COVID, we looked across the skill mixes and across the different professions to support the wards. And so at certain times, a number of the therapists and education staff were redeployed into ward areas. What we've done at the moment is try to maintain them while supporting the wards, still keeping the patient activities integral to what they're doing. So although they're being redeployed as needed through the daily demand meeting, they're trying to be preserved to carry on with their functions and to still work with the patients in the ward areas. I mean, I wouldn't want to try to say that we can provide everything. You know, it refers a little bit to the conversation that's just been had about we can do the basics, we're keeping the patients safe, we're providing the activities that we absolutely, you know, can do in a safe way. But it is tough out there at the moment. This is the third consecutive, you know, month that we've talked about staffing levels, but we haven't had to go into contingencies. So whilst you know, you're sort of saying about the activity levels, we haven't at any point had to go into any of the business continuity plans at Rampton, such as using confinement in the day, for example, or for periods for time, or for periods for patient groups or areas. So whilst it is concerning, we are maintaining safe and effective services at the moment. I think when we get to the forensic section of the performance report, we've talked about our staffing figures, and it's not just COVID. There was a whole array at the moment of reasons that colleagues are not available for work, and I think again an earlier conversation that Steve referenced about, it's a really fine balance of encouraging staff to come and support the wards and to do overtime, etc. But also we've got a duty for them not to feel pressurised to do that, and we're trying to maintain that balance so staff can have the rest. So there isn't such an uptake at the moment of you know, sort of overtime, particularly at Rampton. And whilst I'll continue in a theme because it is mostly about staffing for my areas. You know, Arnold Lodge and Wells Road are similarly, although they're not flagging to such a level, they are similarly pressurised, and because of their size, don't have quite so much robustness built in as they do at Rampton in terms of redeployment opportunities. So it's a fine line that we're managing across the whole of forensic at the moment.
Karen, do you want to come back on that?
Yeah, no, thanks, Sue. I appreciate it's really difficult. I suppose it becomes very, very apparent when you visit, particularly Rampton and the other medium secure hospitals as well, that essentially these places are these patients' homes. They live there for a long time, and therefore not having access to all of the facilities that you know are great there is is unfortunate, and I suppose I'm pushing it because I wouldn't want to see that over a longer period of time. And I have, to be fair, I have witnessed therapists on the wards doing activities with patients, but we're not using the whole facility, as I know you're aware. So it's difficult. I do appreciate it's very difficult.
Sue, do you want to just come back on that?
Yeah, sorry, I got used to holding my hand up there. I don't know if you can do that virtually. I was going to say, so I think the other thing that's important is that there's been a therapist and education review at Rampton, and the way that we want to work with patients to deliver vocational opportunities is different moving forwards, and that is much more around working with patients into their own environments and using all the environments rather than it all being about having to get off, for example, to the assessment unit. So the assessment unit function has closed, and we're delivering that in a different way that doesn't rely on patients being able to get off wards necessarily, but about them being, able to do the work in whatever environment they're in. So I think there is also something about the way that services have been delivered at Rampton isn't necessarily, the way it needs to be continued to move forwards, and TED Review's shown that. So for example, I use this example internally a lot. Some wards might have 2 lounges, for example, but is that necessary all of the time? Do we need to do things in different ways? So there's also a lot of work looking at that sort of stuff around zonal obs and things like that. So yeah, so there's a lot going on, I suppose, Carolyn, in answer.
Yeah, thank you.
Thanks, Sue. And Carolyn, obviously, as chair of our quality committee, I know that you would welcome sight of any further info that comes through, those sorts of developments that Sue's outlining there. Manjit, let's bring you in back to Anne Maria as well. Manjit.
Oh, thank you. Manjit Darby, I'm non-exec director. I just wanted to take the opportunity to firstly just reflect back on the progress that we've made on restrictive intervention. I mean, I think that just from this conversation about staffing and the challenges that we've got in workforce, I think that it is incredible the work that's happened to have a consistent downward trend on restrictive intervention despite all of the staffing pressures we've got. So I just wanted to say congratulations on that, and it is an achievement that we should be really proud of as an organisation, because it's not easy to do in the circumstances that we're in. So just wanted to recognise that work. Secondly, I just wanted Anne-Marie, on the hate crime bit, I know that as a board we'd been kind of watching the upward trend, so it's good to see it coming down. I just wanted to ask about what have we done with the things that people are telling us, and our response to those that are raising concerns. Could you just tell us a little bit about that? That would be really helpful.
Well, helpfully, I had my hate crime meeting this week, so I can tell you lots. Well, there's a couple of things. I've got a very enthusiastic group of people that are really passionate about this area. So we come together to kind of like have ideas, innovative kind of ways of thinking about how we could do things really differently. So there's a couple of things that we've done. Like I said, we have worked very, very hard with the patients themselves to say, what does that feel like? The other thing that we've done is we've done a really good piece on how to report. So we recognise that we needed to tweak the reporting system, and we've done a really big piece of work around how people report it, what they see, and then going back to them to say, you reported this, what can we help you with? There's another thing that we've done as well. We've commissioned Communities Inc., which is a company that have delivered now to over 100 members of staff training around what to do at the point just before the incident occurs. So what do you do just before that point, into the bit where it's just starting to happen? Because what staff were telling us, and a lot of staff said this to us, is we know how to report it because that's after the event, but we want help with the bit beforehand. So what we did is we looked at a piece of work with the psychologists in this trust to come up with something that we could support staff with, to say, this is what you do before the event and before the incident and before it escalates into something that's really, really hateful. and staff have really welcomed that. Now that's rolling out. It's at its very, very early stages, but that seems to be making a massive, massive impact, a positive impact, and staff are saying they really welcome that. So there's quite a lot, actually, if I was really honest with you. There's a lot we have done over the last 6 months. Yeah.
No, brilliant. No, really good. Thank you, Paul.
Great. And Maria, just in terms of you saying there's other a lot of other actions that are being taken that are having impact. I'm sure you are already, but make sure that that's fed through our committees as appropriate, so that we can give it that non-executive scrutiny. Just a couple of comments from me. I think on the hate crime one, my only caution was that we don't get caught up in that lovely technical term of spuddling, and seeing a number coming down from 1 month that's going to be a trend. But you know, I hope that it is the start of a trend, but let's watch that. There may not be an easy answer to this one for now, but just to reflect on Anne-Maria around staffing. For me, there's something about us really making sure we've got those strong localized action plans. So I was at one site where we were hearing recently, where we were hearing about some real challenges on some of the wards around recruitment, and then actually talking on another ward where they were saying, actually, we're okay. And there's something about us making sure that we're learning from where we can. And the other piece with that, again, I don't think there's a necessarily a simple answer to this, but continue to ask, are our systems and processes enabling us to do what we need to do around staffing, or are they getting in the way? So I don't know if you want to respond, reflect on either of those now, or just take those away.
I think I might take those away, Paul. I think it'd be wrong of me just to jump in and try and give an explanation to any of that. Yeah,
great, thank you. Okay, Lorraine, let's come back to you to steer us on to the next piece.
Okay, thank you. We'll move now to workforce and Claire Teeney.
Good morning, everybody. Claire Teeney, Executive Director of People and Culture. A few things just to pull out of the performance report. One, it doesn't respond to that last comment that you made, Paul, around the local systems, but it kind of adds to it, and that Anne-Maria and I can have a look at. Some of the vacancy levels that we've got are not necessarily about turnover and people leaving. They are also a recognition that we've recognised the need to increase capacity in those areas. And I think that the point is right about we have got variability across the organisation. So we've got some areas where the staffing pressures aren't as acute as they are in others. And I think it is important that we focus on our attention on tackling some of the higher order, more urgent areas, which we are doing. We do lose some of our own staff internally from inpatient areas to work in community posts when they arise. So we have got, as an exec team, some ongoing work around that. Other things just to mention, in terms of some of the work that we're doing around culture, a lot of what we talk about through the performance report and through the board more recently has been around operational activity and operational pressures, quite rightly. But it's just to flag that we have continued to do some of the work, more transformational work, around changing the culture and improving the culture within the trust. And we have launched the Creating Capability and Changing Culture programme, which is directly targeted to work with line managers to put in the right interventions to create the right changes around culture within their teams and make sure that they are sustainable. And that actually builds on the work that we started when we did the values and behaviours work, and it is a continuation around embedding some of that. That work took a little bit of a hit when we went into the pandemic, so I just wanted to flag that we've picked that back up and we are starting to roll that out now, which is really good. A few other things in terms of overall absence, that continues to be a factor that is affecting our overall capacity, both in terms of general sickness and that related to COVID. And we are keeping a bit of a watching brief, as you can well imagine,
We have a daily SITREP report, and it comes in, and we will be analysing that quite closely in light of the news around the new variant. To support staff health and wellbeing, we have got a winter wellness campaign. Our health and wellbeing offer continues to be robust in terms of supporting our colleagues, and as of January, in line with our plan, we will have our own full in-house occupational health service. So that is going to be really good in terms of continuing to build on that offer for colleagues. John touched on vaccinations. Overall, the response from our colleagues to getting their COVID vaccination has been really good. In terms of substantive and bank staff, we've got about 482 colleagues across the organisation who haven't had a COVID vaccination there. We've got a task and finish group that has been set up to work through the new guidance around mandated vaccinations. So people have got to have their first vaccination by the beginning of February next year, and letters will be going out at the start of next week to all of those colleagues who haven't yet had that vaccination, and we'll be working with them individually to make sure that we have supportive conversations to understand why that is and support people through. So that's the approach that we're taking, and we have got a combined approach along with Sherwood Forest and Nottingham University hospitals as well, in terms of how we're approaching that across our wider system, which I think is a good thing. To note as well, tomorrow is the first anniversary of the vaccination programme, so it'll be 12 months since the first vaccination was issued, and there'll be a number of things to acknowledge that, and again raise the profile of vaccinations across the Nottinghamshire system. I can't quite believe where the last 12 months has gone as I say that. And the final thing to note is that we did have the staff survey. The staff survey closed on the 26th of November for this year. The response rates are just being validated, but they are somewhere in the region of over 54%. Last year it was 55%, so we'll wait to see what the final response is. Really grateful for everybody who took the time to complete the staff survey. It is really important that we get colleagues' feedback to inform our onward decision making. What I would say is that in terms of what we think the response rate is or is about for this year and last year, that remains over a 10% increase on the year previous. So actually I'm really encouraged that that shows a sustained improved response rate, which I think is really important, especially given the pressures that everyone's been under. There's nothing else for me to add. I'm happy to take any questions, Paul.
Thanks, Claire. Sue Nixon, let's bring you in, please.
Thank you, Paul. My name is Sue Nixon. I'm one of the non-exec directors. Claire, first of all, can I say thank you very much to you and all your team, but also to all members of staff that are coping with very difficult pressures and challenges. So it is good to hear some of the work that you've just highlighted. And I'm also pleased that staff have found time to respond to the staff survey. My question in particular is around the launch of the new OD approach. Obviously, I'm fully aware of this because we've talked about it at committee, the People, Culture, Equalities and Inclusion Committee. But I'm interested to know, in its expansion, what will encourage you to know that the signs of our improved culture are becoming well embedded? Can you give me some indication about that? You know, what will comfort you that's taking force and doing very well, rather than just the numbers of the courses and the people that have been involved?
No, thanks. It's a really good question. So I think a number of things. Broadly across the organisation, it will be in the responses overall that we get for things like the staff survey. We'll also look at a number of other indicators around absence and turnover, which usually are good indicators of what's going on in a team, along with things like freedom to speak up, concerns and the nature of those. So there'll be all of those sorts of things that will give us a feel for what things are like across the organisation. I think more broadly, the OD team are really in touch with a number of managers across the organisation, and it's the sort of feedback that they get from those colleagues directly about how things feel and how supported the leadership within the organisation feels. And we'll also get an indication in terms of the number of things that we're asked and the type of interventions that we're asked to put in from a more corporate perspective. So the position that we have at the minute, and this is why the team have rolled out this kind of approach, is that we are regularly asked to support teams, but when the teams go in and they're specialists in the sort of support that they can put in, it's not really it's the same teams that are asking for the same things all of the time. So what will be a measure of the success is that actually we're able to build capacity and capability within the team directly and support the team and the managers in terms of the culture and the way that they behave and how they interact with each other, and to do that in a self-sustained way. So the idea is that we will be asked for less external intervention because actually the teams are able to do it for themselves. So those will be the sorts of things that we will be looking for and that we will be tracking, Sue. And we'll bring all of that through in detail in terms of progress around the programme through the committee.
Thank you very much, Claire. That's just the sort of thing I was looking for. Thank you.
Great. Manjit, bring you in, please.
Thank you. Manjit Darby, Non-Exec Director. Claire, I just wanted to ask about staff testing. I know that there's no national mandate to make people test given the current environment that we're in. Just your thoughts about how we're managing the challenges of getting people to test regularly and also to report.
Yeah, so I think it's fair to say, Manjit, that I think this has been quite a difficult area for us as a trust. So we do the feedback that we get is that people are regularly testing. It's not being recorded, is what we're being told. But actually, if it's not down, we can't measure it and we can't support it. Whilst there's no particular national mandate around this, it is good practice, and I do think actually we are going to see more oversight and scrutiny on this from NHSIE and a bit more of a push on it again. And we have got a better recording system in place now than we did have. So the support infrastructure is there to enable us to do it. I do think it's something that probably we need to have a bit more of a push and a focus on. What I would say is that we have discussed this as an exec team, and so it hasn't gone off our radar. Our initial focus, however, in terms of landing the right messages with the right people was a couple of weeks ago was really focused around the vaccination. I think that now that's got a bit more into the psyche of people, and we're up there on our figures around that. It's something that we do need to absolutely have another push on.
Yeah, no, thank you. That's helpful. I mean, our kind of outbreaks and COVID related sickness is reasonably low, isn't it? So something is working. I am anxious about kind of where we go with testing and what the national response to testing is going to be and how we support staff to, you know, it's a rigmarole at the moment to get test kits, isn't it? You know, we're not supplying them, we're making people go out and get them and then telling them that they need to upload results. So we're not making it easy for people.
Yeah, it's not easy for people. However, I still think that it's something that we can do better on, and it's about all things, isn't it? It's about vaccination testing, IPC, all of the things. And this time last year, we were in the position of rolling out the test kits. That was the key priority with vaccinations launching, but there was a real push on test kits being available. and I think some of that messaging has dropped off, but I think it's something for us to focus on.
Yeah.
And as I say, I do think that there'll be a lot more scrutiny on healthcare staff and testing requirements as we go forward.
Good, thank you. Great.
All right. Thanks, Claire. So I think, Lorraine, I think we can move on to our next section now. Thank you on the back of that.
Okay, thank you very much, Paul. So we'll move now to Juliet, Outfield and mental health.
Thank you, Lorraine. Juliet, Outfield, Director of Local Mental Health Services. So I just wanted to focus on some of the things that have been talked about already, really the accumulation of staffing and clinical pressures. So just so that colleagues are aware that our local mental health services are by and large declaring an OPAL rating of 4. It does sometimes drop to 3 at the moment, but an OPAL rating of 4 means sustained pressure, in terms of access to beds and staffing. So that's meaning the necessary redeployment of staff, often on a shift by shift and daily basis, particularly in relation to adult mental health. So I won't rehearse some of the things around staffing that have been described already, but it's a particular issue for us. In relation to that escalation, we are particularly escalating into the system so issues around our beds and our patients who are waiting in acute beds for discharge. They are in high numbers at the moment, and there is a deficit of access to specialist placements, and we have a number of patients waiting a long time for continuing care. So that's an area of pressure for us. Also, just wanted to mention briefly out of area. Despite the situation that I've just described, our performance is consistent. The issue for us at the moment is around psychiatric intensive care beds, and that predominantly is our total out of area use, really, other than the odd spot purchase of an acute bed. So what that does actually mean is there is quite a positive way forward for us in terms of improving our performance for the last quarter of the year and into next year. So that's quite positive. It's an issue of getting the subcontracts right between male and female beds, and that's changed. So that's a positive to look forward to, I think, in terms of out of area. In terms of our out of area benchmarking, in the region of the 11 ICSs, we are sort of mid-table. There are 3 ICSs in our patch that are very challenged. There are a couple that are performing really well, and we are fairly in the middle. And that picture is also the same nationally. So we are 19th out of 48 trusts in terms of out of area performance. So that's where we sit against others, but we have some quite developed plans. The risks around some of those plans are, as I've mentioned, getting the appropriate discharge of patients in terms of onward care. We also have issues around the capacity at Sherwood Oaks, bringing that online. It's not so much about the timing, actually, it's about having sufficient staff to open the extra beds that are available to us when we do take on that facility. And that is making us review where we go with some of the subcontracts into next year. So just a bit of a signal around the pressure and the complexity around that's impacted by a lot of things. And you can see the work that we're doing on weights. Generally, that's progressing well. It's the pocketed services of specialist services when we've got the most challenge. I think the one that I'm particularly focused on at the moment is the Neuropsychiatry Service, which is a new service that we've developed, where the demand has vastly outstripped the plan. So it's a fairly new service. So we got some some work to do on the capacity for that service, but it's one that's landed extremely well for patients and families and primary care actually. So I'll leave it there. Thanks, Julie. Steve, please.
Morning, Steve Banks, Non-Exec Director. Julie, this is a question I pre-prepped from reading the papers, and I wondered if it was fair. And given what you just said, it's probably even less fair. However, I might ask it. It's a bit of a challenge. Given what you just said about out-of-area placement days or out-of-area beds, the work's been fantastic, and achieving this and being where we are now is such a big move on. Yet the thing that struck me when I looked at the paper was the zero target in Bassett law, as opposed to the target from our current CCG. Clearly, we're going to be a merged system, so we might expect targets to change. But even if not, and I know you're doing a lot of work in the new strategy. If our target was zero, what else could be done? Or is there still further to push so that the patients in the rest of the system get the same as Bassett law?
Yeah, I'm happy. That's a good question, because it's one I can sort of fairly easily pinpoint. Now we've got to a position, Steve, where we're very clear about what it is we need that we do not provide. So we have a much better steer on it. It's psychiatric intensive care beds that are going out of area. We are lucky in our locality that we can move that comprehensively to subcontracts. There is a risk that we know in those subcontracts, maybe around quality, consistency and securing the service, but we are in a position to be able to do that, and I think that is our sort of short to medium term to actually get to zero. We should be able to do that. We have got to make a decision, I think, very soon about next year. Obviously we're reforecasting because of some issues around Sherwood Oaks, but I think there will be something coming to our executive team next week about proposing the profile and the spend for next year, which could put us in a better place. So it should be relatively simple.
May I follow up, Paul?
Please, Steve.
Thank you. That's great. Thank you. And great you're so open to that challenge. Thank you. So if the board were to support you financially, because clearly that subcontracting it does cost. Clearly we need to do the right thing for our patients. Would you also consider the longer term, whether we need more capacity ourselves, or is that not the best way forward?
No, that's absolutely right. So at the moment we have a company working with us to reprofile all our bed use. That's a part of the long-term plan investment with the CCG. So we've got a co-commissioned piece of work that is exactly doing that, based on everything we know and everything in the long-term plan, what that model should look like. It will, I believe, suggest we need one further acute ward and one additional PICU. I wouldn't preempt the work because it does need doing externally, but I think that's where it'll get us to. We've attended to some of that in our capital bid submissions that we've been asked to, give nationally, although we've got no commitment for that, obviously. So.
No, thank you. I can see our current Director of Finance making notes, so thank you for that. I'll leave it there.
Thanks.
Thank you.
Thanks, Steve. And Julie, Steve's picked up most of a question I was going to ask about, which was around the out of area target. I know that back in the day, April 2020 was set as a target to reach zero. Whilst I appreciate everything that's happened since then, I think for me a piece would be actually being able to come back to us as a board and say, you know what, this is when we think we're likely to hit a zero target, and actually think about what a realistic but challenging trajectory would look like and what we would need to invest in, as Steve identified there. So not one to answer now, but that's just something that I think it'll be helpful for us to hold that, because I think that April 2020 zero target did focus thinking. And I think it will be helpful for us as a board to support you in that focused thinking with a bit of challenge around a target like that. Okay, Lorraine, should we move on? I know we've got, I think, 3 more sections to work through yet. Lorraine.
So we'll move now to Becky, Sutton and Community.
Thank you, Lorraine. So I'm Becky Sutton, Director for Community Health Services. So it's a similar theme really going through today, and some points that Paul and John have already picked up for community health. So as we've already heard this morning, an awful lot of heat in the urgent care pressures and the complexities with social care and the home care market. So we're sort of sandwiched in the middle of some of that in community health. So our teams are working incredibly hard to support where we can, and there's a number of areas. And just a couple of bits to pick up from the IPR. So last month I brought the new community response indicators. So this is a new service. We're ahead of time. This service doesn't need to be until the 1st of April, around supporting people in their own homes to stop them going into hospital. We are really fortunate. We've had an established service doing that in mid-knots for some time, and the figures that we're currently declaring are really quite impressive. Fairly low numbers, but actually all those patients we're stopping going into an acute hospital. We've currently been successful to get more monies into that service, and we're expanding those teams across the whole of Nottinghamshire and Basset Law. So I would expect those numbers to increase from April onwards, and again, a really important service that we're part of. The other 2 bits are really as a result of some of the pressures that we've seen. So you will see in the IPR, we have seen the average length of stay of Lings Bar increase. That is as a direct result of the city social care, home care market, and a number of discharges that are delayed to get home. So we have seen quite a big increase in numbers and patients that we can't get out of hospital. However, we continue to work really closely as a system with our local authority partners, look at alternative ways and whether any of our community services can support in the interim to get these patients home, which is really important for their rehabilitation and their onward care. The other bit that is impacting is you will see again the effect of diverting resources into urgent care means some of our planned care waits have increased. So particularly our 13-week target you will see increased in September and October, and the number of patients waiting over 13 weeks for treatment it has increased. Clearly, again, they're low numbers for community health services, but importantly, we need to keep our eye on that. That is as a direct result of services being rescheduled into urgent care services rather than the planned care. But what we are exploring is alternative ways of delivering that service. So can we offer patients some self-care treatment? What some of the, because particularly in therapy waits, where again we have quite a big issue around recruiting therapists, but can we use a skill mix, therapy assistant and a different way to treat those patients in terms of the treatment that's required. That's probably all I needed to highlight today, Paul, but happy to take questions or comments.
Thanks, Becky. Manjit, question from you, please.
Thank you, Manjit Darby, Non-Exec Director. I just wanted to reflect back on there's been several conversations today just about the delayed transfers of care, and I noticed that in the mental health older people services as well, we're seeing a kind of a rising picture of delayed transfers. We've got the same happening at Lings Bar. I know that we're kind of moving into you know, thinking about, so what's in our control that we can actually do to manage the number of delays, because it feels like there's quite a lot that's out of our hands in terms of kind of we rely on the somewhere else in the system to be able to impact on that. But that causes a kind of, just having visited Lings Bar as well, you know, the pressure that it causes for our services in trying to manage the delays, manage the increased kind of demand of you know, getting patients into the service, but we're not able to get them out. I'm just wondering about kind of whether our commissioners are doing enough to help us to be able to manage that tension, because there is no easy answer, is there? Because if social care is so stretched, and you know, all of our patients that are waiting for something that means that they can actually safely go somewhere other than one of our beds, what else needs to happen in terms of the conversations that commissioners need to be happening? And then just thinking about the waiting list pressures, and the report was really helpful in kind of identifying why the waits are going up. But again, in terms of what the commissioning response to that is, because what we don't want is to be beaten up because you know, our waiting lists are showing red, our delayed transfers are showing red, but those situations are out of our control. Just wondered if you wanted to comment on that, Becky.
Yes, Manjit, and it is really difficult. So I think there's a couple of things in terms of the delay to transfers of care. I think there's one really important thing, that we expose those waits as a system. What often happens is the waits are very much focused on patients waiting to get out of acute hospitals, and what we know, if we don't get the flow all the way through the system, then actually sometimes the home care packages are focused at the acute, and actually we're just causing a great big overflow of bathtubs. So as we work really closely with our commissioners, and I am the senior responsible officer for discharge to assess for the system as well, so we do have daily conversations around those waits. A couple of real practical things: we've put in a weekly escalation meeting with social care around actually how we collectively together can we think creatively around getting patients home. The other bit is to do some work with our staff around actually, are we over prescribing for some of these patients? So again, on a balance of risk, and it's not ideal, but actually, can we use the voluntary sector organisations? Can we mix and match packages of care to support people safely at home, Manjit? And actually, how do we then safety net those patients? So could we get them home on maybe a less package of care that's perfect, but with some voluntary sector input, and then some phone calls with local authority services? And then if they were to deteriorate, could they be purposed through our urgent care response service to keep them at home rather than having to go back through an acute hospital? So they're all the really difficult conversations we're having, and we're having those you know, very often with our commissioning partners. The other bit that we are again doing, which is slightly more medium term, is to look at how we have a really robust and creative recruitment offer across Nottinghamshire, across health, community and local authority. So the risk we've got at the moment is we might put adverts out to support people at home within community services, and arguably because we pay more, all we're doing is pinching them from the home care market. So actually, how can we be really clever across the system, have a really integrated career pathway and do some joint recruitment? And we're really starting to do some of that. That's probably a little bit more established in mid-knots than in south knots, but again, where we're learning lessons, can we recruit on behalf of social care and then second those people in? So they're all the conversations that are happening. The difficulty is we can't recruit as fast as we're losing staff, so there's something around retention. And probably just on that note, Manjit, the local authority have received some funding to be able to bring the living wage in for some of their home care agencies earlier than April, and again, we're looking at how we can give some payment rewards across the system, so bonuses for extra shifts over Christmas and things like that. So whilst it looks quite stark, there is an awful lot of work going on around joint recruitment, around escalating patients and managing risk of patients at home, but it's not easy, is what I'll say.
Yeah, no, that's brilliant. It's really good to hear that. I mean, I think that the challenge for us as an organisation is not being beaten up because our performance gets worse. And you know, it's absolutely clear about the amount of work that is happening behind the actual data that's in the IPR. And it's just kind of making sure that we do have recognition for the leadership role that we're playing in kind of trying to find resolutions when the answers are not in our gift, so to speak. So no, really helpful. Thank you.
Great, thanks for that. Lorraine, steer us on again, please.
Okay, thank you. So the last of our operational divisions, and that's Sue Elcock and Forensic.
Sue, you're muted.
Is that working? Sorry, I've been having some problems with my computer, which is why I might look like I'm not looking at the screen. I apologise. Sue Elcock, Forensic Director and Medical Director. In terms of forensic, I've already talked quite a lot about the staffing, which is one of the big areas of concern for us at the moment. Occupancy, we talk about each month, and the figures are in the report for colleagues to look at. In terms of plans behind that, there are different reasons in the different services which we're looking at. The waits continue in terms of offender health for some of the provision, particularly around dentistry, which some of that is related to activities that were ceased during COVID outside of our control from a health point of view. And so there are plans in place as to how to get those services optimised, bearing in mind essentially sometimes the estate, you know, in terms of room bookings, etc., that really do dictate in some of our prison environments what we can do. Talked about staffing in terms of sickness in particular, but there are other reasons for non-availability of colleagues to be working. We've talked again already under quality about the high secure lone working. So I wasn't really going to point anything out. You've really already covered the main bit.
Yes, thanks, Sue. I think we did take advantage of an earlier item to tease out a number of pieces that related to this section. I'm not seeing anybody indicating with specific questions or comments in addition. So Lorraine, back to you, please.
Okay, thank you. So the last item of the IPR is the finance section. This reports on the up to the end of October, which is the first month of our H2 plan. Our plan is in line with our actuals at this point because the national planning deadline took place after the reporting of the financial position, so it's in line at that point. We have a plan to deliver a break-even financial position over the course of the whole financial year, and we are on forecast. We are forecasting to be able to deliver that. At this point, we're currently just over £800,000 in surplus. FIP, our financial improvement programme identification, is improving. We've reported here in the past about some of the difficulties with delivering FIP in the current operational circumstances. That continues to very much be the case, and we've heard about that through the course of today, some of the challenges that we're operating in, but we now have identified 6 million of the 8.8 million target for this financial year. A lot of that is non-recurrent, just over 50% of that is non-recurrent, but we're not inconsistent with our peers, both in and out of the system, of that balance of recurrent and non-recurrent, again, reflecting those operational challenges. Finance Committee are fully cited to that and have received papers and continual updates about what we're doing to bridge that gap. Capital plan is just short of £26 million for this financial year. We're behind that at this point in time because of the timing of Sherwood Oaks that we discussed earlier in this financial year, but we will spend. Members will be aware of some of the particular challenges around supply chains that have been present in the media and are part of our daily lives within the States as well, in terms of committing to our capital plan. We are as ahead as we can be on our supply chains. We've made all of the orders that we need to make to fulfil our capital requirements this year, and we proactively manage that on a weekly basis with the capital forecast, so we have any early sight to any particular challenges, and we're beginning to do that system-wide as well. Those are the particularly salient points of the financial position.
Thanks, Lorraine. Stephen, please.
Good morning. Thank you, Chair. Stephen Jackson, Non-Executive Director. Chair and Lorraine, perhaps you'll indulge me with several questions, and I'll just go from one to the other and let Lorraine answer in between, if I may. So first of all, it's really good to see the first half year went so well, and you've got that surplus, which is giving you a little bit of comfort. I noticed that the additional income at Rampton has now been pushed back into the second half year. Can you say anything about that, Lorraine? Is it still uncertain, or do you remain confident and leave it in your projections?
So it remains uncertain. Just for clarification, it's not included as a planning assumption in the second half of the financial year, but is recognised as one of the potential mitigations to some of the financial risks that we've got. We continue conversations with NHS England, and I also continue them in the system around how collectively we work together with some of the challenges we've got more widely on specialised services.
Good. At least it's a prudent approach and not being included in the forecast. So that's that's helpful. Looking at the FIP that you've got scheduled out in the paper, there's a significant chunk of what is being identified is non-recurrent, and whilst that doesn't matter too much in the current year, can you describe what issues that's likely to give in the longer term?
So it is likely that any recurrent FIP that is not delivered this year will roll forward. We're not entirely aware of all of the detail at this point in time of how national NHS financing arrangements will happen for 22-23, but we're becoming aware of some of that and hope to know before Christmas, which will give us a better idea. But it is likely that to some extent the undelivered gap will carry forward. Yes, so it does represent a challenge both for us and the wider system that we operate in.
Thank you. Turning to capital now, we're behind against plan, and I think you've explained a lot of that. But we are into now, very close to the Christmas close down. We're very aware of the bad weather and the impacts that has had and how that can impact construction. I mean, how confident are we that we can achieve the forecast spend?
So I'm as confident as I can be, knowing what I know today. I've never been as close to the sort of operational delivery of the capital plan as I have been with this one, given the uncertainties, particularly around supply chains and the market of operating at the minute. Things like Christmas close down are factored into our programmes and our timescales at the moment. So we keep an extraordinarily close eye on capital.
And you'll be pleased to know the last question. On Sherwood Oaks, we've got this additional, or we've got the 3-month delay which wasn't planned, and we're seeing the impact on capital and all of those things. But how would we assess the impact that delay has had on the services we offer, and in particular the impact on our patients?
So I might call on Juliet Outfield to help me out with an answer to that one. Yeah.
Julie?
Yeah, so I'm happy to pick that one up. The delay in itself is not the issue, Stephen. I think 3 months is 3 months. It will impact on us giving us notice on some subcontract beds. The more significant issue for us is if we can staff the extra beds in the 4th ward that it will provide. I think that is the challenge and the issue that will affect us financially, and that's being worked through at the moment.
But presumably, as the work comes closer to completion, you will be able to start recruitment processes ahead of time.
We've been recruiting, Stephen, as if we were having that ward, and we do have a significant shortage of registered nurses. So we've never not been recruiting. We have not recruited the healthcare assistants because that's got a shorter lead in and obviously more availability, but we have been recruiting. I think that's the issue.
Okay, thank you. Thank you, Chair.
Thanks, Stephen. And Lorraine, just to clock, I think the Sherwood Oaks questions that Stephen's picked up there, I know non-exec director colleagues share some of those concerns, appreciating what Julie's explained there. Just we do need to keep a close watch on that. And also just to flag that, again, non-executive director colleagues were reflecting on the FIPs, the financial improvement ideas, and just recognising that without having any desire to wade into operational stuff, just reflecting that there's certainly amongst the non-execs quite a bit of experience around both identifying FIPs, but also that scrutiny around ones that are sustainable. So it's just to flag that, and it may be that there's opportunities for the appropriate committee just to seek a slightly wider set of views from non-executive director colleagues into that, and just to leave that one with you. So thanks for that. It's a really important part of our business, colleagues, and I think we've said this over the last few months. I think our performance report has increasingly got more complex in terms of some of the areas we need to explore in it. So it does take us some time. So no apologies for spending the time on that, although apologies for being a little later to a comfort break than some might have required. So let's take 10 minutes now and reconvene at 25 past if we can, please, and to re-engage with the rest of our agenda for the public board. Thanks very much. Okay, I think we're about ready to restart if we can, please. Let's move on to our next item, which is part of our sustainability work, and it's the Green Plan 2022 to 2027. Lorraine, if I can invite you to introduce this one for us, please.
Thank you, Paul. Lorraine Hooper, Director of Finance, Information and Estates, and the Executive Lead for Sustainability. I have great pleasure in presenting the Green Plan to the board for approval. I'm sure the board is aware through previous conversations that we've had that we are great leaders in the sustainability agenda in the system, with our sustainability team ably led by Lynn Walker. We have here the Green Plan, which sets out the aspirations and the targets that we set ourselves for the period up to 2027 as an organisation, with the overall aim of supporting the NHS get to net zero by 2040. There is a requirement for all trusts and ICSs to have this plan, trusts in place by January, and the ICSs to have this plan in place by March. And we are working closely with system colleagues on the sustainability agenda. Hopefully you will see that we've got 10 areas within this plan, all of which we have endeavoured to do our best to deliver some smart objectives in each of those 10 areas about things that are demonstrably achievable. We have internally to the trust, chaired by myself, which Stephen Jackson is also a member of, the Trust Net Zero group. And I have to say, it is one of the nicest parts of my job to be able to sit with a group of really enthusiastic people who've got huge ambition and aspiration about what we can deliver on this agenda. So the Green Plan is presented here for approval by the board, and then we will go on to incorporate the relevant elements into this in the overall ICS plan.
Great, thanks, Lorraine. Stephen, let me just invite you to add any comments or perspective on this.
Thank you, Chair. Again, Stephen Jackson, a non-executive director, but speaking in this case as the non-executive director with some specific responsibilities around the green agenda. This is an excellent report, and I know that the detail is in the reading room, and it really is a rattling good read, and it is both clear, well written, and also ambitious. And so I think it deserves our support. And I think one thing, just as an example to support what Lorraine said, the ICS is starting to think about its plans and reactions to the green agenda, and I joined Lynn on a meeting at the end of last week. And what became immediately clear was that it's great to see the ICS, taking a combined approach on this, but the presentation that Lynn made, compared really favourably with everything else that was seen, and it just underlined for me, what is a real area of excellence for the trust, and it's really nice to be able to say that this is an area of excellence, where we perform really well, and it should be celebrated. I think the plan is really great. It's here for approval, and I would commend it to the board.
Great, thanks, Stephen. Carolyn. You're muted, Carolyn.
Sorry, Carolyn White, non-exec director. Sorry for that. Just wanted to echo what Stephen had said, is that it is a good read, but I've also had the privilege of just being part of the shortlisting for the Oscars for the Trust, and it's really great to see a lot of low level small projects being put forward by our staff, and shows a real high level of engagement, and it kind of brings to mind the phrase "from small acorns big trees grow." So I just wanted to put that in the mix. It feels like it's a real movement within the organisation.
Great, thanks very much, Carolyn. Lorraine, I'm sure if we went round the board, you'd have echoes of those comments coming through. So perhaps rather than that, we are asked to whether we'll give this approval. So could I just ask colleagues to give me an indication, please, on whether you approve this report, but also that we will agree to accept an annual update report as well, which makes absolute sense to me. Yes, we're getting a good strong response there, Lorraine. Thank you. In which case, let's move on to our board assurance framework, please. Shirley.
Thank you, Paul. Shirley Higginbotham, Director of Corporate Affairs. Here's the board assurance framework. It's presented to board quarterly. I'll take the paper as read, and that sets out the process for reviewing the board assurance framework document. Each one has an exec lead, and each one also goes to a lead committee. So this report reflects all the work done since the last meeting. Probably the only thing to pull out is SR 3.4, which is the one about our sustainability and green plan. The committees are asked to positive assurance or inconclusive, and the strategy committee agreed that this was, no, finance committee, so agreed that this was yet to be determined. I think a lot of work has been done on this, and if you look at the BAF, if you look at that actual risk, there's an awful lot of control and assurance around that. So I think it's because it's new, and we just need to revisit that next time. But we've just described all the good work we are doing with regard to the green plan, so I expect this to turn to positive assurance when it next goes to committee. That's all I need to say, unless there's any questions.
Great, thank you. I'll just see if anybody's got, I've got one comment that I'll bring in a second, but let's just see if there's anybody else who wants to pick anything up. I'm not seeing anybody. Shirley, mine's more of a comment in the detail of the board assurance framework under SR 1.3 is around the diversity in our workforce, and it was just to flag in this meeting something that we've talked about, and indeed other colleagues have talked about separately, about as a board we are keen to just make sure that we're being as ambitious as we can be around the diversity in our workforce, but also diversity in terms of meeting our service requirements. I think it's just useful to reflect on that as something that we will be picking up through board development activity, and that may mean that there's something that then has an impact on the board assurance framework itself.
Yeah, thank you, Paul.
Okay, I'm not seeing any other indications for comments. So in terms of the board assurance framework, we are asked to approve this. I'm just double checking. Again, could we please go for an indication from colleagues about your approval of the board assurance framework as presented here, and acknowledging what Shirley was saying about the committees keeping a focus on those on the contributing elements of the board assurance framework. That's great. Thanks very much, colleagues. And Shirley, then, in which case we will stick with you and move on, if we can, please, to freedom to speak up.
Yeah, this is the 6 monthly Freedom to Speak Up report that's been pulled together by Simbi Simbadna, who's our Freedom to Speak Up guardian. It's a very detailed report. I will take it as read. I think it shows the amount of work we are doing as an organisation, and there's some really interesting comments about how visible Freedom to Speak Up is. We did have a really high level of concerns raised in October, and they've continued into November. We do think that's because October was Freedom to Speak Up month, so more and more people are aware. So we take that as a good thing, that we are becoming an open and transparent organisation. People feel that they are able to raise concerns. Another good thing that we've done, which links onto the EDI agenda, is NHSI have done a project work, and we are the pilot one, which is about barriers to speaking up. And the first one was regard to BME staff and the barriers that they experience. There was 4 workshops, greatly attended and greatly received, and NHSI are very impressed actually. So they're rolling that out to other organisations. There were supposed to be 3 pilot organisations, but we seem to be the only one. So we'll be used as best practice, and that's what's going back to NHSI. It does detail there we need to get a bit more of a focus around managers doing freedom to speak up training, and that's highlighted in the report. Unless there's anything else that people want to pick up on, I think all the detail is there.
Great, thanks Shirley. Again, I'll pause to see if anybody else wants to come in before I do. John, please, John.
Yeah, comment, thanks Shirley. Just to emphasise how important this is for us as a trust, in terms of speaking up generally, freedom to speak up, as we continue to strive to create the right environments for all our work. And what sits behind speaking up is really important to us as part of our the way we do things around here, and the business that we're in, the values that we want to espouse. And this is a really good summary and encouraging progress. There's still a lot to do. I'm not too concerned about the numbers. You alluded to it earlier, Paul, about, you know, what is it, a high number, is it a low number? I think at the moment we're in the sort of time frame of encouraging people to use the facility, and it's important how we respond and close things down, but getting that culture right is critical, and this is a really good summary of the work. Thanks.
Thanks, John. Steve, please.
Thank you. Steve Banks, non-exec, and also with a responsibility as the NED with the link to Freedom to Speak Up. A bit of it's been said, so the bit that's remaining I was going to add was about endorsing the culture change work, the training, those sorts of things being the things that feel like they will make the biggest difference. And I just wondered if we are linking this work, and particularly the developing inclusive speaking up, which is in the reading room, in with our programme management and improvement work. We had a good presentation on that at the strategy committee, and I think this is the sort of thing that we got to link in those together, if it isn't already, could really help to get some focus and to get this work embedded. But again, echo really good work going on in this space. Thank you.
Thanks, Steve. Shirley, did you just want to respond to that connectivity piece that Steve mentioned there?
Yeah, absolutely. We do need to connect it, not only when we're doing service development, but picking it up when we're doing serious incidents or anything else that's happened. It's about identifying those areas in the trust. So absolutely, Steve, we'll definitely be doing that.
Great. Thanks, Shirley. A couple of comments and a question from me, if I might. First off, to say that I was pleased to see that we are getting an increase in people who are identifying as being from protected characteristics or the seldom heard, which I think is a positive thing. I think that does reflect something about trust, notwithstanding, of course, that beneath that there may be issues that we clearly want to resolve. You referenced the workshops, particularly for our Black and minority ethnic colleagues, that and some detail of that being in our reading room. I just wanted to say again in the public arena that within the feedback from those workshops, there were a number of really useful, often quite practical things that we need to be aware of. So responses to questions like, you know, what gets in the way of speaking up? What would good look like if we were being successful in that? And just to say to any colleagues who were involved in those workshops, those comments, they don't just disappear. They're very much a part of what then drives us thinking about how we improve on this. I think a question I'd ask, which you may want to deflect elsewhere, Shirley, was in terms of us just picking up that people still speaking up about examples of racism. Are we doing enough, and what kinds of things are we doing around action on those perpetrating racism? Because I think that's one of those almost a so what that people sometimes frame in relation to speaking up. And whilst I'm personally confident around us taking actions, I think it would be helpful again for us to tease that out.
Yeah, I think what we're talking about is a wider thing, which is closing down, making sure we respond in a timely manner. And I think that's for all cases, including racism. The one on racism is really quite new in the feedback that we've received, and I think that's part of the workshops that we did actually, Paul, so that already forms part of the work plan. In terms of timely responses, obviously we've been living in difficult time, which makes a big pull on time for everybody, but it's definitely something Simbi's working on, and she's working with the champions and obviously managers on that. The more we could get managers to do the training, I think that would be really helpful, because the key part of that training is the feedback element, so how we change things. So those things are all being pulled together in the action plan. I don't know if Claire or anybody wants to say anything else.
I think, Steve, are you wanted to come in on this particular point, or are you on a different one?
Yeah, it was. Yeah,
if we invite you in, and then Claire, perhaps if you just want to give any comment on the sorts of actions that we do take around dealing with racism, or indeed any other kinds of discrimination. But Steve, please.
Thank you. Yeah, just following on from Shirley. So the training is really good. It's well worth doing, and it doesn't take very long. And I think it'd be easy to assume, because we believe in it, it's straightforward, but it was thought provoking. So I'd encourage everybody to do that. The point I was going to make was at the October board, we saw the quarterly update from Simbi, the Speak Up Guardian, and in that were quite a number of the suggestions from people that had attended those workshops. I wonder if Sue would be happy with it. I know it's been picked up in the People, Culture, Equality and Inclusivity Committee. Whether we could specifically consider those recommendations, as opposed, they may already have gone somewhere, but just to make sure they're not just a list of suggestions, they're actually getting properly considered and built into a plan, or not, but it's a proper decision about each of them would be a request, please.
Great.
Thank you.
Thanks, Steve. Shirley, I'm sure, would welcome being able to work out a best route for us doing that.
Yeah, I think Simbi's already doing that, but yes, I'll link back with us, Steve.
And Claire, did you just want to comment on my query there, please?
Yeah, so in terms of some of the actions that we take regarding racism and discrimination, sort of more broadly, I mean, it depends on the nature of the circumstances, and it also depends upon the situation and the person that's been on the receiving end of those sorts of actions and or comments, and other colleagues in that space. So sometimes that can result in quite serious sanctions and formal action, and it is dealt with robustly. In other circumstances, it involves education, support and development. We always offer appropriate health and wellbeing support and interventions to all people that are involved in these circumstances. And I think more broadly, Paul, the piece of work that we are doing and looking at, and the thing that has been flagged, is actually colleagues who discriminatory comments or actions have not been directed at, but have witnessed it, feel very challenged about what they can do to intervene and support their colleagues in that space. And actually that's a key piece of work for us to do, because what people have said is, well, actually we just almost felt a little bit redundant. We didn't know what to do in that space. We were very conscious that what we were witnessing was unacceptable, but we were unclear about what we should do. And I think that's a really important thing for us to focus on. So more broadly, that is a piece of work that we are looking at. What I would just add in as well, Steve had asked a comment about how we kind of link all of this together, and I referenced earlier the OD programme as well, about support for managers around the sort of creating capability and changing cultures. That is a key thread of bringing this together and working directly with managers and teams, so that it's a space where we can bring everything into one space and roll it forward.
Thanks, Claire. John.
Yeah, just to add to those pieces, Paul, and directly respond to your challenge around are we doing enough? Bluntly, I don't think we are. I think there's more we can do, particularly around the racism and our staff and patients' experience of that. We have done a lot of good work. Claire's described some of it, but I do think there's more that we can do, and that's not just a general sort of rhetorical point. I think there's something about being clear on what our aspiration and ambition is as a trust, in terms of, for example, the speaking up is an important part of it, but there's a confidence as well that we need to establish around having some of the difficult conversations and being open to comment and challenge. I think we can, certainly as a board and as an exec, we can embrace that more, and having a clarity of where we want to get to, what sort of trust organisation we want to be. So the exec team's got that on its agenda of, you know, large and important topics to, okay, so we're at base camp, what's the next level? So just to sort of flag that as it's a ongoing major piece of work for us. Thanks.
Thanks, John, and I welcome those comments. I think it also connects with what I'd said a little earlier in the meeting about, as a board, us taking some time to really think about, well, what does our ambition look like here? Because notwithstanding the good stuff that we're doing, you're absolutely right about there's more that we need to be doing. Okay, I'm not seeing any other questions or comments there. Shirley, a couple of bits for you to take away to make sure we get followed up on, but thank you for that item. We next come to the Security Services quarterly report, which also seems to double as a reminder for me about how quickly the months fly by, given that it does feel like not very long since we last saw this, Sue. But notwithstanding that comment, actually it's a really important piece for us as a board. So Sue, please.
Sue Alcott, Forensic Director. So in terms of this report, there's two particular aspects to it. There's the report about the detail of nighttime confinement and the request for board to approve the ongoing use of nighttime confinement, and then the second aspect of it is a significant amount of detail about our compliance across a number of security related areas. So I'll take the report as written and I won't go through it all in detail. I think the key points to highlight are in terms of performance. We no longer have any derogations in place across high security against the security directions, so it's important the board's aware of that. Our training figures, which have dropped due to COVID and in line with derogations that had been in place, are now on an improving trajectory, which we're monitoring closely. Leave of absence figures are obviously routinely looked at, and those have increased in line with clinical demand. The grounds access information is there. We're trying to positively encourage teams to apply for grounds access for appropriate patients. There's information about the testing that's taken place in the last quarter. I think of importance is the security audit, so that's a peer annual security audit that's being done across the three high secures as is mandated, and we received a substantial level of assurance on our audit. We've got an action plan in place to implement the recommendations, some of which are about a good practice as well, so that was really positive. Section there about the high security directions, which I've already talked about. I need to apologise, and I'll omit page 101 from the public board and change it because it shouldn't have identifiable initials in. Somehow that sneaked through my oversight, so I apologise. But last time you'd asked for a little bit more detail about the patients that weren't subject to nighttime confinement. So we've put that in so that you can see the reasons for it, which are on page 101. And so then in terms of recommendation, it's for the board to be assured in terms of our compliance against the security directions, and also to approve the ongoing use of nighttime confinement.
Okay, thanks, Sue. It's I thought there's some really good content in here about just showing some of the progress, particularly in some of the aspects around training, as well as some of the other reported pieces. So that's good to see. And not seeing anybody with any comments or questions, we're asked colleagues to, on a quarterly basis, to authorise the continuation of the night confinement as was described by Sue there, and with the exceptions that are there. So it's important for us to do this. Could I just ask for indications, please, from colleagues? That's great. Thank you very much. In which case, if we move to the summary reports from our subcommittees, and we could go first of all, Trevor, to you for Finance Committee. I think there's both a highlight report and then actually terms of reference for us. Trevor.
Thank you, Paul. Trevor Orman, Chair of Finance Committee. We held two finance meetings in November. The first was on the 8th of November, which was an extraordinary meeting, which was to focus on the second half of our financial year and also a separate review of Impact, the provider collaborative. The second meeting was on the 30th of November, and that was primarily our standard agenda item. In summary, first of all, in both meetings, good attendance and good reports, good papers written by respective owners of subject matter, so that was extremely helpful and continues to streamline the way we're able to look at the critical data. On the second, the core meeting on the 30th of November, really four main subjects that we wanted to make sure as a committee we were assured. First one is that the target to at least break even on our financial position, and we were assured that we have the right controls and procedures in place. The second is on what's already been mentioned, our financial improvement plans, where we've got a target of 8.8 million, and again it's to be assured that the activity on our plans to improve are in place and the relative controls. Our third category is on capital, and we reviewed to make sure we were assured that the procedures and processes of our capital spend and controls are in place. And then fourthly, the business assurance framework relative to the two categories that we cover, to make sure that we achieve our commitments to infrastructure, the financial resources for our infrastructure, and also our financial sustainability, both of which we were assured. Interestingly, a comment that was already made was around our green plan, which was the only item in the BAF that we didn't give full assurance and wanted to have a further review, and that really is only because of the immaturity of that new programme landing on the table, and I wouldn't want to put any question marks around our confidence that the green plan will achieve what we require, and in fact was the 10-point plan was a very good proposal that's already been mentioned. I'm sure going forward we will be assured, but at this early stage it was a bit ambitious to just jump to a full level of confidence against a risk on a very immature activity. So overall, the meeting was well governed, issues were well discussed, and the board should be assured that we had no areas for escalation of specific concern.
Thanks, Trevor. Do you want to talk us through the terms of reference piece then, which I know will require us to formally approve them, if you just want to highlight any changes?
Yeah, so the terms of reference for finance was finance and performance, and we're moving performance into certain categories around the general performance of the trust, not financial performance. We will still retain the oversight of financial performance within the finance committee, but we're also adding in the planning so that we have the overriding review to make sure we are assured on the planning of financial commitments that we require for the trust. So it's to add the planning side of our financial commitments to the financial targets and goals that we achieve. So we're asking the board to approve that change in the terms of reference, and they are in the full details are in the report, but overall a fairly small change in the scale of things, but it gives us a more dedicated focus on the financial performance and the planning of financial goals and targets.
Thanks, Trevor. And can I just clarify in terms of impact, our lead provider role, is that something that you're also scrutinising? I know that we've talked about, I think, the potential of us developing a different committee with fuller scrutiny on that.
That's a good question, Paul. The meeting that we had on the 8th of November, the extraordinary meeting, was to make sure that we do have the right confidence in assurance on impact specifically, and that's why we primarily held that extraordinary meeting. And until such time any changes to what we review in terms of committees, we will retain the oversight and governance of impact within the finance committee, Paul.
That's great. Thanks. Thanks for that, Trevor. That's exactly the clarity I was hoping you'd bring on that piece. Colleagues, I'm not seeing any questions or comments for Trevor. So we obviously received the report on the meetings, but in terms of the terms of reference, could I ask for colleagues to give me an indication of approval or otherwise, please? Thank you. That's helpful. Yeah, I think it was helpful, Trevor, just having that context of if we do, up until any point, we do change governance around those roles, your committee will pick those up. So if we could go on then, please, to the People, Culture, Equality, Inclusion Committee. Sue, please.
Hello again, everybody. My name's Sue Nixon, Non-Exec Director. I'm going to take the highlight report of the meeting that took place of the People, Culture, Equalities and Inclusion Committee on the 9th of November. We had far-ranging discussions on the range of topics here, and actually the content of the board meeting today has picked up the very essence of some of those things we've been talking about. So I'm delighted that we've had such a thorough airing of the importance of freedom to speak up, because that mimics some of our discussions too. The interesting thing I think was good for us at our meeting was our first health and wellbeing report, and I should compliment Tracy Orlandi and her team and all the work that they're doing. There's lots of exciting things they're doing, not only for us, but linked to part of the system. And you may well be aware that shortly, come the beginning of next year, we will have our own in-house occupational health services transferred to us. So that's a really good thing. I'll draw your attention to the equality and diversity and inclusion comment here, because having had an assurance exercise done on this, as you can see, we were given significant assurance, which I think is another really good point there. We've talked also about the importance of learning and development and how we're needing to address compassionate leadership and learning and development and getting that properly embedded to help cultural transformation. And so we had some good debate on this, but I would draw your attention to the fact that the board had asked us whether or not we were using all of our apprentice levy, and that's certainly contained in the highlight report here. So that again is a lot of good work. The board assurance framework had a number of detailed debates, and we were sufficiently assured on all of our 4 areas that we are tasked with addressing. As you know, this particular committee has to drive forward on the workforce capability and capacity risk for the trust, and we've had so much discussion about that even in this board. So it is a real challenge, not just for us but across the whole of the other organisations in the area and in fact nationally. So we were heartened by some of the work that's going on, but we know there's an awful lot more to do. So we did have assurance on each of those areas, also around health and well-being, diversity and compassionate leadership. So it was a good meeting, lots of challenge, but I should add, right at the end of the meeting, before we closed the meeting, in the interest of openness and our trust values, the pressures that have been emerging at Highbury Hospital were raised, and after a number of discussions during that meeting, the committee asked that a deep dive be undertaken and bringing that and the results of that to be brought forward to another meeting. If it can be brought forward to the January meeting, that would be good, but we recognise all the other pressures. But I think it's appropriate that this committee understands those pressures, and that just reflects again the tenor of today's meeting. So that's it, Paul. Good meeting, I think.
Thanks very much, Sue. And then the final subcommittee report this time around. Steve, the strategy committee, please.
Thank you, Paul. Steve Banks, non-exec director. So yeah, just a few highlights to pick out if I can. We were assured in a few areas, firstly to see a carefully thought out and resourced approach to programme management. The digital presentation again was assuring, and the committee wants to continue to look for assurance that the impact will be transformational and benefits patients. So we've asked to see more of that later in the year or next year. And also assured by the ambition of the comprehensive community services transformation. The BAF continues to be very live, and you can see the thread through the risk committee, the board development conversation, and the committee, where the conversations and the challenge kind of makes it a live living process. There was a challenge brought by Trevor, I believe, that I did say I would raise at the board, which was that we're not seeing scores change very much. And I think it was in the summer when we last debated a change and didn't actually make it. We looked at that for the strategy subcommittee and agreed that they should remain the same. But we just wanted to raise that for board awareness and thought going back into the other subcommittees that we need to ensure that continues to be the right answer. So those are the highlights, Paul. Thank you.
Thanks very much, Steve, and that's a really good prompt for us all in terms of reviewing ratings of things, including across risks and our board assurance framework, and being really clear about what is behind the number in terms of each of those ratings. So thank you very much. Couple of AOBs from me. First off, just to reference one, John, in your Chief Exec's report, you'd pointed out that it's Lorraine's final board meeting with us. Lorraine, I just wanted to endorse the comments that John made in terms of your positive impact on the trust here, and also the way that you certainly hit the ground running. I think on about your second or third day you were doing a board meeting, is my recollection. So you were full on in terms of being a participant in the board, and actually you've really helped us embed some critical pieces of work, not just in finance but across things like the digital work, and doing that in the context of 11 months or so of massive change across the system and nationally around finances. You will be missed. I haven't decided yet whether or not I'm going to pick up conversations with my peer over in Leicester about the fact that you've been taken from us so quickly. But I guess I'll get round to that. But we will keep an eye on your impact in Leicester. I know that they are going to be needing and wanting a great deal from you in terms of their transformational work. But thank you from us all as a board for your contribution. And then I also wanted to acknowledge that Steve Banks, actually this is your final board meeting with us, and this is because you have reached the end of your second 3-year term, and you're not allowed to extend that unless we're in real emergency circumstances, which we're not actually as an organisation. And Steve, I know I was particularly pleased that you have been taken on as a non-exec director at Sherwood Forest, which means that you will continue to be a part of our system in Nottingham and Nottinghamshire. And indeed, Sherwood Forest is the first of 5 S's that I was just going to reference. So Sherwood Forest is definitely one of those. You have been the senior independent non-exec director too for us, which has been a really important role. And I think I've really appreciated the way that you've used that to particularly champion freedom to speak up. It's something that you were contributing to earlier today, and I think it's something that you can leave the organisation knowing that you had a positive impact on that. There's also a piece about your ability to hold a strategic oversight as another S, which has been a helpful piece. And I know that as we're going into our non-executive director recruitment round, including for a replacement for you, that is certainly in my mind as something that I want to make sure that we maintain that capacity. A fourth one is about your contribution to system. And actually, you've stepped into some of that rather murky and fluid space in the system for non-executive directors, and really appreciated that. And finally, the final S was your support and challenge of me, which you've brought through your role as senior independent non-exec director, not least of which is including working with our lead governor on carrying out my appraisal very recently. I think that's probably going to be about your last task to wrap that one up, but really do appreciate your contribution to the board and to the trust, Steve. So colleagues, overall, our final piece, just to take a couple of minutes if we can to review how the board meeting has gone today, and perhaps comments on particularly as we've come back to a virtual board. But just let me open it up just to see if there's any comments and indeed any reflections in relation to how we've done in terms of our values as well. So could I just hear from 2 or 3 people, please? Trevor, do you want to start us off?
Yeah, I'm continually encouraged by the way that we're getting through such a lot of material in the board meetings, and I think the contribution from the committees and the structure of the committees is helping that to make sure we stay at the right level. And particular thanks to Shirley for getting the BAF in the shape that it's in, because underpinning what we do is as a board is assessing the risk of what we carry as a trust. And if we don't keep on top of that, then we can have lots of meetings and lots of discussions, but risk can run away from us. So I think that whole process underpins the move and the direction that we need, Paul. So I think that's a very valuable area. And I know we've got some changes that are going on, but I wish Steve and Lorraine all the best in their new roles, and they will be sorely missed.
Thank you for that, Trevor. Anybody else? Let's see if we can get a couple more comments. I think it's important that we do this reflective piece. I'll go Manjit, please. Manjit.
Yeah, I mean, I echo what Trevor said, and I think that the board meeting has been able to give us a balance between the stuff that we are doing well on and some of the progress that we're making despite all of the operational challenges. So, and I think that kind of getting that balance right at board is really important, that we hold on to the stuff that's going well as be really focused on the stuff that we need to support and move forward. So good meeting. Thank you.
Thanks, Manjit. Carolyn?
Thanks, Paul. I think there's been a bit of a theme through the meeting today around the pressures in the system and particularly on our staff, and we probably haven't seen the worst of that yet during this winter. So just something, it's good to hear that coming through the board and the support that's been given out there, but something that we need to keep a focus on as we move through the next few months, I think.
Thanks. I think that's a really helpful reflection, Carolyn. And John?
Yeah, thanks. I thought it was a good meeting, Paul. Thank you. I agree with the above comments. And although we spent a lot of time on the performance report, I think it was well used. I think there was a good conversation and challenge from the non-executives, and that, I think that's the sort of territory we need to be in as a board. And I'm sure I can't speak on behalf of the exec, but I think that they would find that it was well balanced. And as Manjit said, you know, it's sufficient time reviewing sort of the rear view mirror, but also looking forward to the future. So yeah, good meeting. Thank you.
All right, thank you. And I'll just close with saying a thank you to Lauren and to Grace, who are behind the scenes, in part making sure that we're able to have a smooth meeting, but also working hard on making notes to inform our minutes for next time. So thank you very much. I think the last thing, colleagues, that is for me to wish you all as good a Christmas as is possible. We will see one another in the new year. Please continue to stay safe, and to say thank you to you for all your work during this last year as a board. It's been a really tough year, and we've been a part of that too. And just to acknowledge all of you for your contribution. So thank you, everybody. Colleagues,